Hi, I'm Sharrie Harlin-Davis, and welcome to this episode of Reid Beside You. And today our guest is Dr. Quraishi from Reid Cardiology. And welcome.
Hi, Sharrie. Thanks for having me.
The first thing is we always like to ask people how did you come to Reid and how long have you been here?
So I did my training at Wright State University and cardiology and interventional training at Kettering Medical Center. I think this was in 2015. So since 2015, I've been here at Reid. It's been a journey.
Well, we're very happy that you chose Reid. And another thing is so that you didn't have to drive too far since you studied at Wright State and we're at Kettering. So
yes,
that's great. Today, we're going to talk about a newer procedure that you're doing. And I'm going to let you use the big words. And I am just going to ask you, what is TAVR?
Yeah, so that's we call it TAVR all the time, but it stands for Transvascular Aortic Valve Replacement. In Europe, it's actually called TAVI. Instead of replacement, it's called implantation. So this procedure has been around now for a while. I would say it's been about 15, 16 years since it's matured into a durable and good technology.
And with that, so what is the big difference? I know it says it's a minimally invasive.
Mm-hmm. So we've been moving towards non-invasive procedures. And this has gone in general throughout the world as technology has matured. Our treatment options have also improved. In the 70s, 80s, we used to do a lot of what we call as aortic valve, open repairs to replace the valve, in that the sternum would be cut open and the valve would be replaced. This trend still continued into the 90s, early 2000s, mid 2000s. And we noticed that as patients were getting older, their comorbidities were increasing. They weren't doing so well after the procedure. The mortalities were higher, the complications were higher. So then we started, as we developed balloon angioplasty and stenting, we thought we can use the same concept in the aortic valve. And by early 2000, this technology was developed, in which we mounted a valve in a stent over a balloon, and we started to replace these valves in a minimally invasive way. We used to do patients under general anesthesia. That means they were intubated. We had a lot larger sheets. The procedure was a lot elaborate. The complication rates were still high, but now this procedure has matured to the point that we make a small hole in the artery in the groin or somewhere else if patients aren't suitable. And we are able to do it under general anesthesia. And the recovery rates are a lot faster. The complications are a lot lower. And literally patients are able to walk out of the hospital in 2 to 3 days' time.
And can you give me an example of what from a traditional procedure versus the TAVR procedure?
So like I said,
actually what I meant was how long would the recovery rate be?
So the recovery rates would vary. It would vary from 3 to 5 days. Now with TAVR patients, most of these patients are able to go home within 3 days' time. As a matter of fact, I just read a study that patients are even being discharged the same day now.
Wow.
Yeah, so this procedure is evolving to become a very safe procedure and a very good option for patients with good durability.
And as you were describing it earlier, you mentioned a word that I think a year ago, the average person wouldn't understand what that meant. And when you said that comorbidities, and now after going through COVID, there's so many other words that the general public understands.
Right.
So if there's been one good thing, we've learned a lot of medical things that we never knew just on regular procedures. What are some of the benefits for using this procedure for patients?
So the biggest benefit is in terms of complications and recovery. Patients don't have a chest that's cut open. So in terms of sternal wounds, sternal infections, we don't see that at all.
Mm-hmm.
We see a rapid recovery. Patients feel better within the next 24 to 48 hours instead of a lot longer after surgical procedures. And then we have to understand that most of these patients that we're taking care of are above 75 years of age, and they have a lot of other problems. So their outcomes are much improved through this minimally invasive procedures, really a life-saving procedure.
One of the, when I was reading, so to help our audience understand, I read it says it replaces your old heart valve, so oxygen-rich blood flows in the right direction. Can you explain that in better terms than I just read?
Yeah. So most people who develop this problem are above 75 years of age. It's called calcific degeneration of the valve. So as a process of aging, as our structures in the heart are subjected to flow of blood, they degenerate and calcium gets deposited on the valves. Just to give you an example, if you look at my finger, a normal heart valve would open this much. In patients with severe aortic stenosis, they'll open up like this, like through a small straw. And that's the amount, and that's the area the heart has to pump blood to the rest of the body in this disease condition. So in this procedure, we are able to place a balloon through that small opening and deploy a valve. So imagine from a straw opening to a larger opening, you get rapid, immediate improvement in circulation to the rest of the body. And most patients feel the difference immediately. Within the next 24, 48 hours, they say, yes, I can breathe better. I'm not feeling that tired. When I walk around the room, I feel more energetic. I don't feel that fatigue.
Right.
So it's a very neat procedure.
What are some of the symptoms of the problem that would lead to having this procedure?
Most patients are actually asymptomatic. They won't have that much of symptoms. Generally, the patient's family members will notice that the patient has started to limit themselves. If they used to walk 2 miles, now they're walking like maybe half a mile or a mile. So they generally, subconsciously, they start limiting their activity.
Okay.
Once they become symptomatic, the predominant symptoms are shortness of breath. And as it progresses, they develop chest pain, lightheadedness. And at the end stage, they start passing out.
Cool.
And that is also a possibility of passing. And that's like the end stage of the valvular problem. But most patients that we end up seeing are asymptomatic or they're short of breath, limited in their activities.
So being looked at, having like your friends are noticing it or your family members are noticing it's a big hint that there's some challenges.
Right.
I know another thing is that what's it made of? When you're trying to go into the procedure, I saw something that said a wire frame or something to expand. Can you explain that?
Yes. So it's the easiest way to understand it. It's like a steel frame in which there is a valve that's mounted. And all of this is on top of a balloon. So once we put a wire across that small opening, we're able to push that stent that's been mounted, the valve that's inside the stent and mounted on a balloon through that opening. We just flare that balloon up and it kind of crushes the native valve against the walls and we have a new valve in place. So that's what it is.
Okay. And also it said there were 4 different types of approaches.
Sorry, what? 4 different types?
I read about 4 different types of approaches. Do we have a standard approach that you use? Or?
So we are in early development of our program, and we have been using the groin approach, which is considered the safest approach for this procedure.
Mhm.
But as we continue to develop our program, we will use other approaches like the subclavian approach, which is a subclavian artery, the transapical approach, which is through the tip of the heart. I'm not sure we're going to be doing that, but I know for sure we're going to continue to develop our groin approach and maybe the subclavian.
And all of these, and I know that they're all approved through Medicare, Medicaid, and often coming from the financial side, I always get those different kinds of questions from an insurance basis. So we know that all of these procedures have been approved through CMS.
Right.
And which is very important because we want you to get paid too. So and who's an ideal candidate for this procedure?
The ideal candidate is anyone above 75 years of age who has symptoms. That would be an ideal candidate. Now, in our country, we've been doing more and more trials, and it has shown to be a procedure that's safe in people even under the age of 75. So the indications of the procedure has expanded to people who are above 65 years of age, who are considered to be low to moderate risk. But ideally, if you look at it, we have to look at this procedure in a way that, is the patient going to come back? How durable is the fix? So anyone who's above the age of 75 would be an ideal candidate.
And I'm also, I see that we were joined by some other people that work with you. Mm-hmm. And if possible, Tyler.
Hey, can you hear me?
Yes, we can.
Hey.
What would you like to add something just on the success of the procedures or something that you'd like to add? And this is Tyler Evans.
Yeah. Hey, everybody. No, I think it's just been a big testimony of the hard work that Dr. Quraishi, Dr. Elbash, and Dr. Chowdhury have put into getting all the pre-work done. This is a fairly newer technology in the grand scheme of things, and something that requires a lot of kind of behind the scenes work as far as surgical coverage and training. There's been countless hours of them going to be proctored and building policies and procedures to guide all of this. And seeing some of these patients walking down the hallway a few days later after the procedure, it's pretty rewarding to know that they didn't go through maybe the more traumatic experience of having their more invasive procedure done, and their quality of life is just instantly improved. I think this Wednesday we had both cases done by, I believe, 1 o'clock. So to think that two people had a second chance to have an improved lifestyle within a couple hours of a day is pretty rewarding that way. But it takes an army behind the scenes. But luckily we have 3 physicians who have really owned this process and realized the value in it, and then have worked with Lindsay Hobson, our valve coordinator, with our programming in the office to identify these patients. So at any one time, there could be a small list of people who are ready to go and a very long list of people they're tracking. So Tammy Carmen in the office does a great job of continually checking in on these patients, making sure the proper testing's done, and then getting the people in front of the docs in a timely manner. But really, they've done a good job of prioritizing the right patients, the safest patients, and then taking their time to make sure that we've done this the correct way. So I think we've done 6 so far since we started into December, with plans to continue to grow those numbers all year so far. But thankfully that every case in the procedure has gone well, a lot of communication, a lot of teamwork again with all of that. But it's been pretty rewarding to see something that's been, as an organization, I think Cheryl said we've been working on this since the mid 20 teens, with multiple attempts getting really close, and then for whatever reason not being able to kind of complete this. And we had until the end of last year to get this going. I think we did our first TAVR case the last week of December with 3 days left to spare in the year. So to say it came down to the wire is an understatement, but it didn't happen by accident by any means. So very fortunate to have the team we do.
And I'm sure that's a little thing called COVID kind of stopped everything in its tracks. So
If it wasn't hard enough, yeah, to mix in COVID, it's always a challenge to everything. Again, the perseverance, the team did not let that stop them. It required even more of that. So everyone did a good job kind of buckling down and not being diverted away. When so many other programs were stopping or slowing or even shutting down, we've actually taken large steps in growing the program, especially with the structural heart advancements of TAVR. So we're very fortunate to be able to keep moving as an organization that way.
And as an organization, the cardiology area is so important. It's actually one of our larger areas, so that is very well known. So we thank all of the people in the cardiology area, and also Tyler, thanking you, because this is the first time we've had a person that's actually working with the doctors and representing an area. So now you've given me a new idea to express from the behind the scenes how an actual area is working.
Glad to blaze that trail for you there.
As well as, and Dr. Quraishi, what's some other things that you want us to know about the procedures?
I want to let my community and patients know that we are here to take care of them. We provide a large variety of solutions to cardiac problems, and we strive to be the best in the whole area. So if anyone needs anything done, if they have aortic valve stenosis or any other problem, we're here to help them.
Oh, that's great. The what's the probably number one thing when people are coming in? Tyler, do you have your people from your area or the coordinators talk first before they get to the physicians like Dr. Quraishi?
Yeah, there's actually several kind of layers to the process there. It all starts with just identifying patients who could be at risk and then getting the appropriate testing. All that is then kind of entered into a database that our valve coordinating team reviews, identifies people who are low, moderate, or high risk. Those in that high risk category, even moderate risk category now, are then identified and then presented to the doctors. And those who then are identified as needing a valve repair would go to our heart conference, where we have a multidisciplinary team made up of cardiology, peri-op, surgery, ICU, quality. Several members of the organization reviews every case one person at a time. They identify if a TAVR versus a SAVR, which would be more of an open valve repair, is appropriate. Everyone has to come into agreement with the treatment plan before the end of the meeting. So it's very good to get everyone around the table reviewing risk factors, the benefit over everything. And sometimes we even result in medical management as the best option. So by no means we push anybody one direction. After the determination is made by the team, whether it's surgery versus a TAVR, they then see our valve coordinator, Lindsay Hobson, who's a nurse practitioner. They see Dr. Elbash, our structural heart medical director, and they also see Dr. Sala, our cardiothoracic surgeon. So everyone has their part of educating the patient, making sure they feel comfortable, they know the risk going into the procedure. But everyone supports everyone. So there's no egos that get in the way. If it's a surgery, or it's a TAVR, if it's medical management, everyone knows that the right minds are around the table to make that determination. And sometimes it's patient's not ready yet, put them back in the queue, and 6 months, a year from now, we'll revisit it. So there's a lot of factors that go into all of that. But we have a really good team, a really good echo and sonography team here that does really great about capturing the images and measurements we need to make sure that we have the proper equipment, the right valve sizing. They have a heart cath done to check out the anatomy of the patient. So really every part of the service line is involved in one way or another, from the diagnostic testing, the heart caths, from the office visits, and then up to the day of the procedure. Really everybody has their hands in it at one point or another. But that's all just to ensure that the patient has the safest route to their ultimate procedure that way.
And I'm glad that you talked about that the different areas meet together, because being out in the community, I will often have someone might say, they didn't take me for that particular surgery, and I because I'm working at Reid, I understand why, but because there were some risk factors, or you might have needed to lose weight, or you you had other heart problems, or there's so many different levels. And I'm really happy that you're explaining the team and how people look. A lot of people at your hospital, and they just think, okay, they're going to take me in there to have this particular surgery, and without realizing there's a lot of underlying areas that you're looking at.
Yeah, especially even for TAVR. Lindsay actually prepares an entire PowerPoint presentation for every patient that is a TAVR candidate that outlines every aspect of the patient's health, comorbidities, risk scoring. So I do think a lot of people would be happy to know how thorough we are. It is by no means just a quick, this is the patient, this is what we want to do. It is a very in-depth conversation with a lot of people around the table, and everyone, like I said earlier, has to be in agreement with that decision. So no one can kind of dominate the conversation or force the decision one way or another. We've got a really good group who speaks openly like we want. That's what we need when you're making a decision like that. And then we ultimately want to come out and what's best for the patient, and not necessarily just trying to get somebody on the table or anything like that.
Yeah, Tyler, I'd like to add to that, and I think you've seen it too multiple times, that if we felt that the patient is not a suitable candidate for our facility, we've even sent that patient out to another one, keeping the safety of the patient in mind. So if we can't do it safely, we won't do it. Absolutely. We have our patient's interest in mind. That's the greatest thing to us.
Absolutely. We have a great relationship with some larger organizations and maybe offer a little higher level of post-op recovery needs, or maybe just have a higher skill set. Obviously, we're just starting in TAVR, so we're not overly confident that we do it better than anybody else yet. Our goal is obviously to be that top center, that we can handle all those higher risks, but we realize it's a learning process. So yeah, if it's a situation where an operation or a TAVR is the best case, but we have a confidence that somebody can make sure it happens correctly, we have no trouble at all meeting with the patient and then sending them to those kind of tertiary organizations.
If someone was had a family member or even themselves, and they felt that they needed to have it checked out, what would be that procedure?
I think the first thing is just talking, if they don't have a cardiologist, talking to their PCP, talking to their primary care doctor and letting them know they have symptoms. And then we have a really good primary care network relationship with our cardiologist that'll set them up for that initial referral. And I think the biggest thing is just don't discredit symptoms sometimes. I think people chalk things up to, I'm just getting old, or I was sick a little bit, but it's always worth getting checked out. If you're feeling a little more short of breath, if your energy levels are going down, you just can't make it as far as you once did when you're moving, it never hurts to ask the question. You know, there's some very non-invasive stuff that we can do early on as far as screening that can lead to later things. So it's not like everybody who thinks they may have an issue gets a heart cath or gets a surgery consult. There is several steps before that that are very pain-free, non-invasive, very cost-efficient, that can at least give us an idea if this is the way we want to go or not. And then Dr. Quraishi, you can kind of lead on what you look for and what you take from there.
Exactly. So we have a good relationship with our primary care physicians, and the first point of contact is the PCP. If anyone feels that they have any problem, they should talk to their primary care doctor, and they'll get them to the right place.
And I know that you're the PCP with referral, but you are actually you're actually in the hospital. Your location is in the hospital?
Yes.
Okay.
We're on the second floor, right above the main entrance there by the MOB. And then we also have cardiologists who are rounding in the actual hospital. So patients who are admitted can actually see a cardiologist as well, then get follow-up in the office. But outside of the hospital location, we have outreach offices all around the community around us. So sometimes these patients are from Hagerstown, from Brookville, from Connorsville. So it's not just the Richmond location. These patients can be identified in.
Oh, great. And well, I want to really thank both of you, Dr. Quraishi, as well as Tyler, putting you on the spot really fast, and how you quickly responded. We want to thank both of you for joining us today, and thanks for joining us on Reid Beside You. Thank you.
Thank you.
Thank you.